we're going to go ahead in the discussion by having a panel discussion. Our distinguished speakers, Professor Edwin Esegbe, Professor Ikeoluwa Lagunju, and Mr. Charles Nkwala will be joining us. As well, we have a distinguished nurse practitioner in the person of Mrs. Shoni Barry. Please, ma'am, maybe you be upstanding as I read your citation. Mrs. Dorcas Olukemi Shoni Barry is an articulate, self-motivated, skilled, and adaptable nurse midwife. She's an educator and a nurse administrator born over 50 years ago in Lagos, in Surulere. She attended both primary and secondary education in Surulere. The quest for nursing education took her out of Lagos in 1984, after which she was employed as a staff nurse in private hospitals in Lagos before she was offered employment into the Lagos State Public Service 30 years ago. She worked as a clinician in various hospitals until she became a clinical instructor of midwifery students in 1995 and a nurse tutor under different administrations. She also worked with 3 directors of nursing services in Lagos State Ministry of Health. She has practical experience in coordinating nursing issues at tertiary, secondary, primary healthcare levels, as well as in educational and industrial nursing in Lagos State. She's highly motivated, focus-driven, and a good team player. She's a strong and assertive personality with a clear vision of the nursing education standard that befits the Center of Excellence. A good teacher, manager, and leader with a vision of mentoring students and subordinates for continuity, she has to her credit over 18 awards and over 65 presentations at seminars, symposia, workshops, and conferences. Mrs. Shoni Barry is a fellow of the West African Postgraduate College of Nursing. She's the secretary to the Forum of Directors of Nursing in Southwest region of Nigeria. She's the chairman of the Lagos State Nursing and Midwifery Committee and a member of the board of London Professional Training Lagos Center. Even in her place of worship, Mrs. Shoni Barry is still rendering her health services as she's also a board member of the Foursquare Gospel Church Hospital, Idimu, Lagos. You're welcome, ma'am. Another round of applause for her. Professor Segbe, Professor Lagunju, Mr. Nkwala, Mrs. Shoni Barry, please come up to the podium. Thank you. So we are taking the discussion further by getting opinions from our distinguished panelists. Thank you to all who also logged in online virtually and participating. We will take your comments from the chat box. So my first question goes to Professor Esegbe. Prof, stunting remains a public health challenge in the developing world. Is stunting reversible? And is there a critical window of opportunity to reverse the impact of stunting? And are there any cutoffs?
Okay, so stunting is not reversible generally. In other words, you don't have a child who is 3 years old, stunted, and then you put that child in a nutritional program and the child recovers, all that has been lost. So from that perspective, it is not reversible. However, there can be damage control. So there's a window of opportunity to effectively check the consequences of stunting. And that is amongst children who are between 9 months and 24 months. So having said that, it doesn't mean that if you find a 3-year-old or a 4-year-old who is stunted, that you throw your arms up in the air and say, well, you know what? At that particular point in time, what you'll be doing is that you'll be reducing the impact or the negative impact that stunting ordinarily, would have brought into for. However, there are some studies that have looked at the fact that you could still get some reversal, not absolute. For children during the early adolescent period or up to the early adolescent period, which is called the mid-childhood period, between 6 and 12 years and between 11 and 15 years. But again, these are scientific, these are outcomes of scientific inquiry. But generally, the whole idea is to avoid stunting because the consequences are virtually irreversible. We listened to the lecture by Professor Keolo Alagunju talking about, brain development taking place even before the woman knows she's pregnant. How do you reverse all of that, if you allow stunting to take place? So there is a window of opportunity between the 9th and 24th month, and subsequently you will be able to carry out or effect some damage control, but not in that reversible perspective. Thank you.
Thank you very much for that, Prof. My next question goes to Mrs. Shonibari. Ma'am, nurses are considered frontline healthcare providers. How do we begin to make growth monitoring a key nursing practice in order to pick growth faltering on time in children?
Thank you very much for this opportunity to talk about child growth monitoring amongst nurses. I want to say that child growth monitoring is one of the key factors of activities that nurses undergo in all our facilities. And I believe, why do we do this? From the lectures that we have had today, we are made to know that this is very, very important. But I want to say that in our local governments, our general hospitals, and even in our tertiary institutions, the child monitoring activity is very key. And what do we do? This is done at the level of the child welfare clinic, where the anthropometric measurements of these children are being taken, recorded. But I want to lay emphasis here that the aspect of charting those statistics is very, very key. And it's not just taking those measurements, you should be able to compare it with the previous readings and must be able to interpret if this child is actually gaining weight or is losing weight. So apart from the aspects of child monitoring through the anthropometrics, the midwife or the nurse is expected to encourage exclusive breastfeeding, even though this ought to have also commenced from the first hour of birth, if this child was delivered in the hospital. Apart from that, we expect also that apart from exclusive breastfeeding, the mother should also be educated on the different types of food substances that will help this child to grow. That is after 6 months of exclusive breastfeeding. And you are now commencing a period of weaning for the child. So the nurse midwife should be able to explain to the mothers during the health talk in the hospital. So apart from the health talk, the aspect of vaccination, the immunization of these children is also key to the development of these children. These are the activities in our various hospitals. And I know that nurses are doing it, but I know they have challenges, okay? It's not just doing it now, but doing it properly, because we are looking after the growth of these children, babies. Because by the time a baby is brought for immunization, especially the third aspect of the third aspect of the immunization, that child is expected to have doubled the birth weight. If that child was 2.5 kilograms at birth, by 5 months, it's expected that the weight should have doubled. Okay? So apart from that, we expect that also the mothers must be given health education continuously. Not just the mothers also should be able to pass it across to those that are taking care of their children in their absence. I hope I've been able to.
Yes. Thank you very much, ma'am. So my next question is to Professor Lagunju. Prof, let's look at DHA, which you talked about so much, and the typical Nigerian diet or Ghanaian diet as it stands today. In your presentation, you called out DHA as a critical building block of the brain, important for several neurodevelopmental processes. Are these children consuming enough DHA? How do we ensure they meet and even surpass the minimum DHA requirements?
All right. Thank you very much, Dr. Yenusi. Well, I think it's glaring that Nigerian children as well as Ghanaian children, from the statistics we've listened to today, are not getting enough DHA. Because we see that the exclusive breastfeeding rates are really very low. The figures are abysmal. And even beyond the 6 months, many babies stop breastfeeding. So we see that, and the point has been made today, that breast milk is a critical source of DHA for children. In addition, beyond the 6 months, when they need the complementary feeds, babies, infants, young children are not getting the appropriate diet. And this we can put to dietary, cultural factors, poverty, low earning power. Parents can't afford the appropriate kind of diet that the children need. Another important thing is, I talked about the cultural factors. So there are some cultural beliefs, children don't need protein. If you give young infants protein, you will teach them to, they will learn to steal. We see those things are wrong. And in talking about DHA, fatty fish is a major source. So how many children get fish in their diet? So these wrong cultural beliefs have to be done away with. Another important issue is ignorance, and the fact that mothers these days want the most convenient kinds of food, the very fast ones, the ones they will cook and they will finish cooking in 5 minutes, in 10 minutes, So such have actually done a lot of disservice. So mothers need to begin to pay attention to the balanced diet. To improve the DHA content, we must keep hammering on the issue of exclusive breastfeeding for the first 6 months of life. Infants need to be breastfed at the age of 2 years, and then when complementary diet is introduced, we must ensure that children get these food sources, particularly fish, eggs, chicken, in their diet. Thank you.
Thank you very much, Prof, for that insight. My next question is to Mr. Nkwala. Sir, how can we implement community-based nutrition interventions for growing children? And can you elaborate on any successful nutrition programs that have been implemented among African nations?
Okay, thank you for that question. There are several ways you can implement a community-based nutrition intervention for children. But the way you use depends on the available resources and even the time. But there are about 5 key things that you must do for any intervention to be successful and for any intervention to be effective and sustainable. The first is that there must be a situation analysis. You have to know the characteristics of the community, the nutritional needs of those children, the nutritional problems of those children, and also the likely causes of the problems in that community and possible solutions that are culturally acceptable. Because if you don't do that, you will not meet the target. Secondly, the community-based program must have ownership. The community must have ownership of the program, which means that the intervention must start and end with the community. You don't just design a program and you dump it on the community. It will not be effective and it will not give the desired result. The third is that any intervention tool we use must be locally available and must be locally accessible and culturally acceptable. The fourth one is that the intervention must be innovative. We must use innovative approaches, which includes multi-sectorial approaches. We don't just do it alone. There are different people that will come together to achieve this. And also, there must be a sustainability mechanism. Most times, interventions don't have sustainable mechanism. The last point is that it must be periodically evaluated to check whether these children are actually having any progress, whether the intervention is meeting the needs of the children and the community, as the case may be. Yes, there are several successful programs in Africa, like the intervention, they call it the iLife intervention in Malawi, that took place between 2004 and 2009. It led to reduction in stunting and malnutrition in Malawian children, and it was quite successful. The second one is the Ethiopia experience that happened in 2008. It was successful within that period that it reduced stunting. Let's even go to our sister country, Ghana. The intervention they did from 1998 to 2008 that increased or doubled the exclusive breastfeeding and early initiation of breast milk breastfeeding in the children was successful. But the problem with most of these community-based interventions is the sustainability, and that comes from the design. If it is not factored in, there will be a problem with that. Thank you.
Thank you very much, Mr. Nkwala, for that. I come back again to you, Professor Lagunju. How can we assess whether a child's neurodevelopment is occurring appropriately? Are there early signs to be mindful of impaired neurodevelopment? And how do we differentiate between developmental delay and neurological conditions like autism or cerebral palsy?
All right, thank you very much. Mrs. Shonimare did talk about monitoring the growth. Indeed, development in children should be monitored. The same way you put children on the scale to get how big they are, use the tape to see how tall they are. They are skills that we use, and these are simple questions that we ask mothers about the children's development. So the starting point is to ensure that each time a child comes into contact with a healthcare provider, we ask specific questions about the development. And this we call the developmental surveillance. For the pediatricians and those who work regularly with children, we know that when we take a history, we talk about the developmental history, and we ask routinely, what's this child been able to do? When did this child sit? When did he crawl? Is he making words yet? So that you do in a flexible way. But more importantly, we need to have what we call screening tools. At the moment, we don't have anyone in Nigeria indigenous, but we're close to it because very soon we hope one will be available. And so these babies are taken to the routine infant welfare clinic, or they come to the hospital and we ask those questions. And based on the responses of the mothers, we're able to see whether or not these children are developing appropriately. So the appropriate screening tools. And then now talking about how we know. Mothers are usually very sensitive about their children's development. And they are usually, oftentimes, particularly in countries where this routine assessment are not available, they are the ones who come forward and say, I don't think my child is doing things right. He's not doing it at the right age. He's not doing as expected. But unfortunately, rather than healthcare providers looking closely, we give false reassurance. We say, don't worry, he will catch up. And that's really very unfortunate, because when it comes to developmental assessment and intervening, the earlier you know there's a problem, the earlier you institute an appropriate intervention, the easier it is for the child to catch up. So this child will not just catch up under his or her father's roof without any intervention. And the last thing, the second part of the question, how do you differentiate developmental delay from developmental disorders like autism and cerebral palsy? Indeed, at the middle of this is developmental delay. It's just that the domains of the development that are affected differ in the two instances. A child with autism will be able to walk on time, crawl on time, run. Looking at him or her, you may not even know that there are developmental problems, but communication, social skills, behavior, these areas will be impaired. And but for a child for cerebral palsy, the major problem will be the motor milestones, when the child is able to hold the neck and do the other things that have to do with the motor development. Thank you.
Thank you very much, Prof, for that expansion. I come back again to you, Professor Esegbe. How frequently should growth monitoring be done? And what are the red flags that we should watch out for while monitoring?
Thank you very much. The frequency of growth monitoring is actually a reflection of the growth pattern in the child. So in the first year, where the growth velocity is highest, let's look at a parameter like weight. It's important we look at what is optimal. And what is optimal is, apart from at every visit, we should be able to take the weight of this child, every month. It's important. In the second year of life, we can do that every 2 months, and then subsequently every 3 months till the child is 5 years. With regards to the height or the length of the child, it's also important that this is done at least every 3 months, and then subsequently in the first year, and then every 6 months in the second year until the child is 5 years of age. Now, I do know that this can be very tasking, but we can only intervene. We can only deal with deviations from normal if we notice or we identify them early. And once we begin to get this into our practice, we suddenly realize that, we can do this. Now, we're talking about what the red flags are. The red flags will be dependent on several factors. Now, if a child visits, a health facility, it is important that that child's growth is monitored, using the growth charts. On the growth charts, we are supposed to plot at every visit points at which the child, is weighed or height taken. Now, when we notice deviations from normal, whether too steep, very flat over a period of time, those are red flags. Red flags can also be identified from the complaints of mothers or caregivers. You have a child that is described as that is too short, having small body parts, or whose body parts, for example, the head. This child has a small head. Nobody in the family has this type of head. So from complaints, you could also institute or elicit red flags. There are some children whose condition, ab initio, signifies the red flag. For example, those who are preterms. If a child is born as a preterm, that child is already having a red flag all over it, and you must monitor that child regularly. And of course, there are children who also they are presenting with nutritional disorders. Mothers might not note them, but you as a physician or as a healthcare provider or practitioner, you notice some of these issues. For example, the child who is presenting and on examination found to be anemic, having skin changes pointing towards micronutrient deficiency and so on. So these are ways in which red flags can be elicited, in under fives. Thank you.
Thank you very much, Professor Egbe. I come back again to you, Mrs. Shonibari. Professor Egbe has talked about how we should be monitoring growth frequently. So I ask, do you consider the present nurse-to-patient ratio sufficient to achieve this objective of early detection of growth faltering?
You can hear the response from the audience. Now, considering the nurse-patient ratio is a crucial factor at this point of our life as a nation. Now, nurses are actually traveling in droves. Nurse leaders have nothing less than 3 letters, either withdrawing their service, resigning their appointment, or voluntary retirement from service. 3 every day, minimum. So you can imagine the situation in which we are. So what are we trying to say this morning? Is the fact that WHO has proposed that every nation should have a minimum of 1 nurse to 50 population, and a doctor to 400 population. Okay? Which means that if you divide 250 by, that is 250 by 27 million in Lagos, you can know the total number of nurses that is required in this state, which is a far cry from what we have. All right? So on this note, I want to talk about what Lagos State is doing, because we cannot just watch and see things going the other way. So there's a policy on ground that we call exit replacement policy. As the exit, we refill. As the exit, we replace. Because Lagos is proactive. So apart from that, we equally have the nurse graduate, hello. We also have the nurse graduate, one house. We are trying to resolve issues here this morning. Yeah, so Lagos State also has this policy of, it's a national policy anyway, that graduates of nursing, of Bachelor of Nursing Science from all our universities should undergo 1-year internship. And I have well over 7 accredited institutions in Lagos for such, both private facilities and public facilities. So what am I trying to say this morning is the fact that the ratio is a far cry to what is required. But at the same time, I want to advise, because for me to make this presentation, I made visit to some institutions, and I realized that when nurses have large number of children at the child welfare clinic, they call on the lower cadre to assist them. While some institutions call on the nutritionists and the dietitians to assist with the assessment of the growth of those children. So we should also look inwards to how we can solve our problems and not just sit at it that, after all, I am not Buhari, but I want to say that every one of us in our little corner, we should be seen to be doing what is right and the little we can do to help our people. And lastly, before I drop the mic, I still want to talk about the aspect of we need to supervise what our subordinates are doing. Now, if nurses have taken vital signs, head circumference, weight, we should be able to look in, is it properly done? Are they having the right interpretation, which we can now take forward to diagnose the condition, the health status of these children? So the aspect of nutrition, as we have discussed today, is very, very vital. And it can be a precursor to the issues we are having in Nigeria that has to do with insecurity and the complications of COVID and psychological situation of many of our adults today, which commence right from utero. Thank you very much for listening.
Thank you very much, Mrs. Shonibari. So, obviously, from what you have said, the ratio is inadequate, and we're also having brain drain. So, there's a clarion call to the community at large, to the country at large, for a way to retain our healthcare professionals so that what needs to be done in monitoring the growth of children, in interventions, can be achieved. Thank you very much, ma'am. My next question is to Mr. Nkwala again. From your presentation, sir, several studies show a strong correlation between milk, cognitive development, and even linear growth. And studies also show, however, that in some parts of Africa, children consume little or no milk. So what can we do to improve milk consumption, especially age-appropriate milk among Nigerian children?
question. Thank you for the question. I think I have to break it down into two. That the approaches we'll use, we have one as nutrition education approach and government policy approach. Now, in the nutrition education approach, we have to emphasize on the health benefits, the social benefits, and the economic benefit of exclusive breastfeeding. Because milk consumption starts from 0 years. So we have to emphasize on exclusive breastfeeding. And this emphasis should also have the economic benefit of it. Now, this nutrition education will be at the household level and at the community level, including the men, which are the fathers. Most times, they are forgotten in this enlightenment program. But from experience, I'll tell you that the fathers are the major decision makers on exclusive breastfeeding and continue breastfeeding for beyond 2 years. So I think if they know, we will achieve that. And secondly, there is something we always, as healthcare workers, we always assume that the caregivers know what to do, that they just don't want to do it. Most times in the community, I'm a community person, I found out that they don't actually know. So the nutrition education should be there. Now, the government policy should ensure that you have an environment, a conducive environment that sustains exclusive breastfeeding and continue breastfeeding for more than 2 years. And what are these policies? 6 months maternity leave is one of those policies. And it should be carried and be a national policy. And also, it should be implemented and monitored. Not giving 6 months to a mother to stay at home and be doing other business, not giving the child breast milk. These are things that we should do. Then, when the child has grown beyond breast milk, are we going to leave the child that milk is no more important? No. There should be nutrition education also on the importance of milk, especially for school-age children, so that they will know the benefit. And not only knowing the benefit, the skill on how to incorporate milk into the diet of these children, economically and sustainably. Government policy should still come in there, that we ensure that milk is available, affordable, and accessible to these children. For instance, the school feeding program. We can ensure that milk is one of the foods that should be given to school children during that feeding program. This will help to make sure that milk is consumed. From infancy, exclusive breastfeeding, continued breastfeeding to 2 years, and beyond that, incorporating other milk in the diet. I think if we do this, we are going to have that wide milk consumption behavior. Thank you.
Thank you very much, Mr. Nkwala, for that contribution. We have an online audience, and they're also participating. So they've asked some questions. The first question is to Professor Lagunju. There are actually 2 questions that are tied together, so I'll read them so that you can take them together to save time. The first one says, should DHA be routinely prescribed for all children? Should it be for only specific persons? And then Chinyereze is asking that, how do we handle children that refuse to take animal foods like fish, meat, and so on, since DHA is critical for brain development?
Oh, thank you very much. And I'm quite happy, particularly with the first question, should DHA be prescribed? And the answer is no. We've talked today about the importance of DHA, or in my talk, I made a lot of emphasis about that. But the best source of DHA is in the diet. For the infant, let the infant get it in the breast milk. And then for the other children, proper complementary diet. Please let's not encourage parents to go around buying DHA tablets. That is not the message. So please, it's not indicated. And so the money they would have used to buy those tablets, please let them put it into giving the children proper food. Okay? And then the second question is
how the children who refuse.
Oh,
the picky
children
eaters.
who refuse. That's very interesting. You know, children, I mean, in infancy particularly, they are learning. So if a baby, you introduce something new today, the baby refuses, you must keep at it. You must keep at it. You must seek help if you are not able to. Baby, if you don't devote time to it and you're not committed to it, babies don't like trying new things. They are very comfortable with the kind of food they like and they want to stay with those. But there is no child that you will not succeed in being able to feed with animal protein. So please, we must do that and ensure that we succeed at it. Some people are really very, very good at this, but our nurses are really particularly good with this, the community nurses, the public health nurses, and so when they come around, we give the health education, and once you get the required assistance, there is no child that will not receive the fish and the chicken. Thank you.
Thank you very much, Prof. Then there's another question. I will pose it to Mrs. Shonibare because the person called out nurses. So, Cyrilano Shiriki says, how do you address the low acceptance and practice of exclusive breastfeeding among the health workers, especially the nurses in health facilities who are supposed to be the role model to the nurses on the promotion of exclusive breastfeeding?
Thank you very much. Nurse midwives are supposed to be role model to mothers. And I think I am one. I've given my personal experience that, you see, if you have not experienced something, you may not be able to fully put it down for others to consider. Experience is always the best teacher. I know out of my children, the one I gave exclusive breastfeeding for left university and created his own job. He told me, even during youth service, Mommy, don't send me to any place that they'll be tossing me up and down. I will work in my own company. And he created one. It can be as serious as that. So, my dear colleagues, experience is the best teacher. Please encourage yourself and your colleagues to be a good example, role model to mothers. Whether you breastfeed or you don't breastfeed, the breast will sag. So please give it to these children. Give it to these children. And those days, my students asked me a question. Who owns the breast? Is it the father or the child? I said it's the child that owns the breast, but the father can loan it. Or the other way, it is the father that owns the breast. We loan it to the children, but please give it to the children. Give it to the children based on what we have heard today, that the impact of exclusive breastfeeding has a lot to do right from development. You heard about the neurogenesis of development of the brain. It needs the content of the breast milk to grow. Thank you very much. I think
Thank
I've
you very
answered the
much,
question.
ma'am. Yes, and Mr. Nkwala wants to contribute to that discussion, especially because he's done a lot of work. You know, he's in the community. But before you go ahead, I will also ask the question that someone posed to you, so you will take it together. It says, Mr. Charles Nkwala mentioned investing $1 and getting $16 in return. The question is, where and how do we invest this dollar?
The two questions are in line with what I wanted to add. First, let us get this clear. My wife is a nurse. Yes. Now, my wife did exclusive breastfeeding for the 3 kids because of my support. There is something I observed, that you train somebody on the knowledge of exclusive breastfeeding is not enough. When we are talking about capacity, it has to do with knowledge, attitude, and practice. Most health workers are failing in the aspect of attitude. If you don't have a positive attitude towards something, no matter what the knowledge you have, you cannot practice that. And that's one of the things I had to develop with my wife. We had a good understanding on the attitude. Why do we need to invest on this exclusive breastfeeding? By the time we started, it was not easy, but I supported her. And she was able to see that. And during the period she was exclusive breastfeeding our first child, her cousin came and gave her an experience of her second child that she didn't breastfeed, that she saw the difference between the first child she did exclusive and the second. Because in the second, she felt that there was nothing much of a difference. So we did that and it came out rightly. Look, it saved me costs in terms of dollars. I never went to any emergency hospital for all my kids. I am a living witness, and I say it proudly, that I never had an emergency case where a child had to go and you spend money. I didn't buy formula. So I don't know the cost, because the breast milk is there. And look, let's get it right. The breast is for the man, but the milk is for the child. So you have to have that understanding with the man to be able to know when the child needs to breastfeed, the child needs this milk. And whenever the man wants the breast, he knows when he gets his own. So there must be that support from the men, and we must have it in rightly.
Thank you very much, Mr.
Investing
Nkwala.
$1 to
Yes.
now investing $1 to get $16. Let's get this clear. A stunted child, what is stunted in the child? The brain is stunted, the heart is stunted, the pancreas is stunted, everything is stunted.
Charles, I'm sorry.
I welcome our father in pediatrics, Professor Abiodun.
I'm sorry I have to get up at this stage. Because of what Charles said. He said the breast is for the man, the milk is for the baby. We are not talking of exclusive breast milk. We are talking of exclusive breastfeeding. Is it not so? So I think I will have to modify what he has said. The site of the breast is for the man. The site, the man can look, but the breastfeeding is for the baby. Do we all agree with that? So the shape of the breast, the depth of the shape is for the man. But the child can suck whatever the site, whether it is down or standing. Do we agree on that?
We agree.
Because we are talking of exclusive breastfeeding. We are not talking of exclusive breast milk. So both the breast as well as the milk for the sucking will be for the baby. The husband, the man can look and look and look. Agreed?
Yes. Thank you, Prof, for that. Now, investing $1 is such that, let me end with that. Investing $1 to get $16 is just like what our mother here said. that any child that you invested in exclusive breastfeeding, you will not go to the hospital for emergency. You have saved that money. You are not going to have extra expenses. Moreover, this child grows to become intelligent and create job for himself and for others. So you have gotten the benefit of this, and the economic value is even more than $16. Thank you.
Thank you very much. You must agree with me that we have had a very robust, rewarding discussion. So I thank my panelists, Professor Segwe, Professor Lagunchu, Mr. Nkwala, and Mrs. Shonibari. Thank you very much.